Hi, everyone. Welcome to Foresight's Biotech and Health Extension Group. I'm really excited to finally have Evelyn Bischof here today with us. We've been in contact with you for years now, on and off. We've been trying to schedule something. We're really excited about your work, and you've been definitely really ramping it up over the past few years. So I think it's a really great time to have you on. Today, you will be discussing in the group about healthy longevity medicine in the clinical practice, which is definitely a topic that I think has become rather of interest lately. So I'm really excited for the Q&A afterwards. I'm sure people have lots of questions and comments and, contributing similar efforts. So without further ado, thank you so much for joining. I'll share a lot more about you in the chat, but for now, please take it away. We're excited to have you.
Thank you so much. It's a great honor and pleasure to be here, and I'm grateful for this opportunity, and really congratulations to the Foresight Institute to do it and to do it on such a scale. I will share my slides, and of course, very much looking forward to the Q&A session, which is usually much more engaging and valuable. When I was choosing the topic, I tried to be a little bit broader because I would like to not only discuss, whatever people already discussed in terms of definitions and in terms of what we want to do with health span versus lifespan versus the theory for the clinic that we know. I just really wanted to talk a little bit about practical examples of what is already being done across the globe, and then really to say what is planned as in agenda by specific societies or groups. So I would nevertheless love to start with an announcement and a warm invitation to ERDD conference. This year, it's the 11th time that it will take place in Copenhagen. It's, I guess by now, one of the largest aging and longevity conferences. And since COVID, basically, we also have an integrated time-specific slot for longevity medicine session. It grew from a workshop to half a day to last year a full day, the opening day. And this year it expands further and it will be a whole longevity medicine track. So it will be the full first day. And on top of that, also other tracks along the entire conference. Longevity medicine track will really accommodate for the clinical part and allow not only clinical discussion, but clinical trial discussions and really have a platform for doctors and healthcare professionals and affiliates to discuss various topics. And usually we also have a co-moderator that graciously allows us, to co-host the day. And last year it was Michael Baxson from Nature Medicine. Before that it was Nature Aging. Before that it was Lancet Healthy Longevity. This year it will be revealed a little bit later. But one thing I can already reveal is that this year the conference will be also co-organized more or less, or will be also done partially in partnership with Express Healthspan. And especially with Jamie, where we are structuring the first day, the longevity medicine day, a little bit together to be more aligned. Let's do it hand in hand, since Express Healthspan is really focusing on how can we do something for the patient and how can we bring the research to the clinic. So this will be also the time where the endpoints will be announced and the guidelines of the prize. And another that I want to mention that I usually always mention in my presentation, but here I would love to also make a few announcements, and whoever is interested to join and collaborate, everybody's always welcome, is the Longevity Education Hub. So talking about Healthspan, healthy longevity medicine, whatever we want to do, I think the first step is always education of physicians, education of healthcare professionals and others. But myself, I only know medicine. So I was focusing on the education of the doctors, and we created a longevity education hub, which is offering free courses that are CME accredited by the AAMCA for introduction and then also expanded course. And doctors who pass the quiz, over 80%, can also get the CME accreditation. And it's still, for the past 4 years, it's been existing, still the only course that's CME accredited globally for longevity medicine, which is a very nice thing because we went to build national chapters. And I think we have right now about 10 chapters covering 80% of the globe, with Spanish, with Chinese, with Arabic courses. And the thing that really was in our long-term vision, which is starting right now, is to bring this curriculum into med schools and also into residencies and fellowships. So really the last part, the practical part, of the education of the doctors before they become specialists, so that we can really advance the field and bring more clinicians into the field. And, the dream is really to have medical students finishing med school knowing what is really longevity, knowing the mechanisms of aging, and not to learn them as they go. And mostly they have no time to learn it later. So those two big announcements before I move on. And usually I always start with this slide because for me, until it changes, it always reflects longevity medicine. It's a story from Alice in Wonderland when they're running with the Red Queen. And after running very fast, they stop and they're in the same place. And, Alice is asking, why are we in the same place? And the Queen is saying, if you want to actually advance, you have to run double as fast. And that's pretty much what healthy longevity is for me. So we are constantly running because there is just so much knowledge from geroscience, from AI, from computing. Now with generative AI really becoming a mainstream. And at the same time, we really also want to advance. So that's a full-time job and a little bit more. Since, again, we do not have healthy longevity medicine yet as a separate discipline. So those who actually practice it usually have also another foot somewhere else in their own home disciplines, or they do this, but then it's very difficult to integrate it into the typical healthcare setting that we have right now, the healthcare systems. And that's a little bit of a problem because it then remains something relatively closed. But before we go into that, I would just like to mention how the definition of healthy longevity medicine or longevity medicine has been evolving. And it basically started a little bit in the year 2021 with the publication in Nature Aging based on ERDD presentation of Dr. Kai-Fu Lee, saying that longevity medicine is basically AI-based precision medicine focusing on the health span and the lifespan. It was pretty much the first time that somebody, said it and published in this way. So it's not only the lifespan, it's primarily the health span, and this is powered by AI technology. Here, we meant mostly the biological aging clock. The definition has been transformed a little bit when Healthy Longevity Medicine Society was found. Some of you might know it. It is a society that is actually creating a platform to further bring longevity medicine into the field as a subdiscipline, probably first a subdiscipline under internal medicine, which also, of course, includes family medicine, and then to hopefully also a separate discipline at all, or not. Definitely, it has to be positioned as something where the doctors can be certified, can be educated, certified, qualified properly, and also have the way to have the so-called continued education to always be on top of their knowledge. And, this society, when we first came together in the executive committee, we were thinking long time and discussing, brainstorming, and came up with the definition that healthy longevity medicine, actually this healthy came on top of longevity medicine as we were talking to really distinct ourselves a little bit from what longevity medicine partially became along the years. And instead, definition will be optimizing health span along the lifespan by targeting age-related processes. So really, including the fact that we are working on age-related processes rather than on aged populations. Of course, we learned from them a lot, but it's not only the thing, and it's a health span target across the entire lifespan. And that's the committee. Here, I just wanted to mention that, many familiar faces, but one face might not be so familiar. This is Professor Harold Pincus, who is a psychiatrist. He's the head of psych at Columbia and Presbyterian. And this is just to say that in healthy longevity medicine, very often we don't forget, and we always keep in mind that brain, cognition, and also mental health is very important. But actually, to practically have that integrated into a healthy longevity medicine society, I found that very important, and I was very happy that this happened. Now, as we are talking about bringing healthy longevity medicine into the mainstream healthcare, into something that can really be practiced, we need several things. Of course, it's a puzzle, but we have to start somewhere. And we started with a bunch of white papers. Actually, our most recent paper was out, I think, a week ago or something. It's called Building longevity departments in public clinical settings. You can look it up in geroscience, which is actually telling about how did we, as the working group of HLMS, which is constituted of Mayo and US and Sheba Israel, how we came towards building longevity departments in the public settings, from building the team to educating healthcare professionals, to finding the budgets, to finding the right diagnostics, of course, and to also interventions that are already being done for those patients who are coming to the departments in the public setting. But then also we will hopefully very soon have a paper on the actual definition of longevity medicine, and then further white papers will be coming now. Of course, we immediately jumped on education. So since the beginnings, August 2022, we already had our monthly case discussions in HLMS, where not only medical doctors, but healthcare professionals and affiliates were able to really discuss cases. We didn't want to call it case presentations because we all do not have yet binding guidelines and recommendations for healthy longevity medicine as in clinical setting. But it was important for us to have a platform to discuss among those who actually practice it or who are planning to practice. And that is still happening. But a very important overarching goal is really to create guidelines for longevity medicine and quality controls for doctors and for clinics. So have a set of, as it is done for any other discipline and as it is done in any other setting where clinics and doctors have to be undergoing quality control on ongoing basis, and also where a discipline has a set of clear guidelines. This is something that we want to achieve. And this has to start first with building guidelines and how to build guidelines for longevity medicine, which is very different than in any other discipline that is focusing on sick care. Not only because of the ICD coding that is very different and focused on pathologies, of course, but also because at this very moment, there is just not enough evidence in clinical trials on many things. One would say, then how can you build guidelines? Well, we would start, of course, as always, with the lowest level of guidelines, which are recommendations, plus 3 or C, whoever wants to call it which way, and then to build it up towards guidelines, both in interventions and in diagnostics. And of course, we have to start with diagnostics because the most important thing right now for the success of clinical trials is the definition of the right endpoints, and those are the biomarkers of aging. And luckily, within the last, almost 2 years now, we have big consortia of aging biomarkers, both the aging biomarker consortium in the US, but also big biomarker consortium in China, and both of them are doing a great job to build it up. Here, just to show once again, where are in the world already longevity, I like to say longevity departments, one might say longevity centers, where people can come and undergo some level of longevity diagnostics. For our center here in Sheba, it's fully for free. And we will have this year 1,500 people who will undergo 360 screening for longevity at baseline 6 months and then 12 months. All of those people will be in a study. 80% will be randomized into interventions and will be given or are given interventions for a year to come, and then there will be a crossover. So on the one hand, that's already a service for people coming from across the country to be screened, but at the same time, of course, the endpoints, which will include the biomarkers, but also compliance, will hopefully be something that can be presented to health insurances to say it actually makes sense by the economical calculation to implement some sort of program in the packages and to have people giving the accessibility to such longevity services. Overall, of course, it's an ongoing learning. And as we are learning and translating healthy longevity medicine, I think almost every month we are adding something new into the center, being from a new technology for diagnostics to some new clocks that are out there, new signatures for methylations. That's extremely fun to do and beautiful. But at the same time, really this tertiary digital layer of the patient expands. It's a lot of data. It's a huge amount of data. And it's a data lake that is hard to handle in clinics that are primed for sick care, that have been in the system for years and decades and more. And so the EHR really has to expand in a way that only a center that is really open-minded can do, which is very interesting. And of course, without AI, it's impossible. So it's very important once a center has decided to be a longevity center and be at a scale that is, goes into thousands rather than hundreds. It's very important to have, besides of the strong IT in the background, besides of the strong data lake capacity in the background, also an AI arm that can fuel in all this information continuously and hopefully be connected to something that is teaching a very large LLM. So large language models, I think, in health and longevity medicine, as we speak, are being trained. AI is learning constantly. There are big transformers being conducted and done. Some of the publications are already even available. I will show them in a moment. And one has to think about that as a doctor who is creating or running such a department, to have this in the background. So what one can see on the surface, all the testings, all the center equipment, all the doctors who are there as they usually would be. The power is in the backside. The power is in the AI that is behind it. And I think we are seeing really a constant revolution of what the field is. So when we tried to do a timeline, we saw there was quite a fast progress in general up until the year 2015. Even, we had the hallmarks of aging, the seminal publication, we had the Harvard clock, which was, for me personally, a huge revolution. I remember learning it at the med school, and, it really transformed and shifted our mindset of doctors from telomeres to there might be something more in terms of aging. There's something more that controls it. And there was, also CRISP coming up. Then really the biggest point came, I think, in the year 2015, where we started to see more and more AI in medicine, and all the omics revolution came up. And then also deep aging clocks were coming. And this is thanks to the fact that around this time, the deep neuronal networks were developed and really applied in order to really have the data analyzed, first structured, and then analyzed in a way that would bring a functionable objective out. This something that is usable, such as biological age, right? And then the wearables came. So healthy longevity medicine without wearables and very good integration of those wearables in the API in daily use is impossible. So it's very imperative to use it. And then the clinical trials and supplements came, and more until now. Even as I mentioned, we have large language models, we have transformers that are being built, and that's something that I'm extremely excited about. Actually, healthy longevity medicine has been using generative AI for a long time. It was just not as, accessible to people until ChatGPT came out. But it was already being announced, and deepfakes and everything that generative AI was allowing us to use was already being applied in order to, as I mentioned before, be able to integrate, structure, and analyze the at large scale, longitudinally, but also data that is really extremely heterogeneous and multimodal. Because for healthy longevity medicine, we have to go from the omics through the systems, through the organs, lab tests, radiomics, actually at this point of time, historical records, a very deep anamnestic records, and so on, up until the point that we also try to get as much data points as possible from the epigenetics. So from the environment, the influences on the person itself that actually change the epigenome. And that was only possible with the learning methods that allowed us to get some sort of objective function out of it. The objective function mostly was personalized medicine advice, recommendation, and right now much more, for example, AI-based drugs, which we'll talk about just in a moment. Now, as I mentioned, deep neuronal networks were tremendously important for that to happen, but also other versions of learning. There are good sources to learn about it. There's actually a chapter in a book called AI in Longevity Medicine that is talking much more deeper about cellular learning and transfer learning that were used in order to get what we call today biological aging clocks, but also other personalized recommendations. And as I mentioned before, generative AI in longevity medicine has been used already before, really to integrate all the data sets from those very different data points, extremely heterogeneous, through the neuronal networks into something that is actionable for a clinic. For example, what is the aging pathway that is being targeted? What are the synthetic data out of it? What are the potential trackable targets? How to build a drug out of this information. So that was already happening. Now, going out of this deep AI, how does it translate to an actual practice? What can we do? And how is longevity medicine different from prevention? How is it different, or how does it fit into also our reactive medicine reality? So I don't claim that this is the right way to see it. For me, it just helps to see it this way that, of course, we have reactive medicine and it will not disappear foreseeable. We treat diseases, we react to a disease, and that's important. And basically, any doctor has to know how to do that. Then there is prevention from primary to tertiary prevention. It's a proactive approach. We detect early diseases. So therefore, the disease is already there, or early recurrence, right? But there is already a pathology that we detect. And we detect early in order to remove and treat that pathology. So that's also great. And that's very well established. And there are clear guidelines, and that's very important. Now, what's different in healthy longevity medicine? Depending on the scale, how it's being done, it can encompass also prevention or be an additional part to prevention. I think both variants are totally okay. And for example, for us, we separate, right? We have a specific other center that is doing prevention with all the screenings, with colonoscopies, mammographies, and others. And we do the extras, right? From the functional testing to the methylation to biological age and so on. But there are centers that integrate both. Also fine. That goes hands in hand, but it's still different. And in this part, really longevity medicine is about detecting the risk of developing a disease and trying to assess the gravity or the dimension of that specific risk for a specific patient and bring the patient from current status of different markers to the optimal status of those markers in order to optimize the health span. And I'm probably repeating myself when I'm talking to the experts here, but nevertheless, I think it has to be said, we are extending our life expectancy tremendously fast, and it has expanded in the past 100 years, but the health span didn't expand at the same speed, and therefore we have the gap. And so healthy longevity medicine is really trying to close that gap. And so primarily, it's really not about further extending the lifespan. For some people, it is, byproduct that is desirable, which is great if that's the desire. But it's really about closing the gap of health span and lifespan and extending the healthy years of life. So basically, age and disease, so death, with good health. And because the definition is optimizing health span along the lifespan, we are talking about also really optimizing a point of life that we could call a peak performance or peak individual performance. Basically, in normal real world scenario in medicine and beyond, we would look at patient's chronological age along the lifespan of a patient, and we would see that the patient is going, through a curve of life. I'm sure you've seen that before in different places. That's actually taken from the Nature Aging publication. So we basically see a patient who is, being born, and until the adolescence is being usually guided by one or two doctors, neonatologists, pediatricians, and we all know the norms. So everything is very normative. There are ranges by chronological age. A child has to achieve this and this and that within a specific age. That's basically how it's being done. Until the person is reaching this level, which is the peak individual performance. This is usually a short interval of our life where we have the top functionality of our body and mind. And from that moment on, it's a functional decline at different pace for different people. And usually this is also where different doctors are evaluating the person within norms that are mostly based on chronological age, but not only, but these are the norms. We have the normative values and we usually in the clinic, we look what's outside the norm, what's within the norm, and then we try to act if needed or if possible. And that's pretty much it. Of course, there are limitations because doctors' memory is extremely limited and there is dispersion. If there's 2 or 3 doctors looking at the case, there will always be a problem to bring everybody together at the same point. So there is a lot of information that is leaking, and usually that leaked information is not beneficial for the patient outcome. So the decline is going towards very often a very comorbid or multimorbid end of life. Now, in health and longevity medicine, as you can see, it's not a tremendously extended lifespan here. So the length of life, the years of life might stay the same or maybe a little longer, again, byproduct. What we are really trying to focus here is to have the patient being as close as possible to patient's personal, individual peak performance. So how we do that? We are trying our best to develop and to use biological aging clocks and really to evaluate the patient with algorithms that are trying to tell us not only how old the patient is biologically at a specific point of time, but also what would be the optimal biological age of that patient at that specific point of time and which parameters need to be fixed in order to bring that patient back. And for this, of course, we are mostly using longitudinal data. I usually tell patients, please do share with me anything that you have from your old data, simply because the more, the better. And the more longitudinal in the past those data points are, the better the predictions of what can be optimized. And so therefore, longevity medicine is really standing on 2 pillars, in my opinion. We have the diagnostics and we have the interventions. And luckily right now, the intervention part is growing more and more. A few years ago, it was primarily diagnostics. And there was a lot of criticism saying, why do we do all this? We have nothing that we can really do about it. And the answer was, if we don't test with this new longevity diagnostic precision medicine, and if we don't fuel it into the algorithm, we will never be able to identify the right endpoints, the right biomarkers for clinical trials. And this is exactly what was happening in the past years. And this is why, luckily, we see more and more of those endpoints and biomarkers being validated and therefore useful for clinical trials. So finally, we can test which supplements are beneficial for extension of Healthspan and which are not, and also repurposed drugs, and also hopefully very soon new compounds, both senolytics and geroprotectors, and also technologies, right? And to check if they are beneficial or not. So what is happening are mostly now, as you surely know, in the longevity diagnostic centers, we have a full span, again, going from either only longevity diagnostics or preventative and longevity diagnostics, ranging from whole body MRIs with overlaying AI algorithms through other radiomics, through functional tests, through labs, very extensive lab, and also through wearables, and also through more and more liquid biopsies, and of course, omics and microbiome. So microbiomics, one could say. And hopefully very soon, a much more bigger panel on biological aging clocks. And what already was established and is now being even more important and useful in the clinical practice is the polygenic risk score. So really having the mosaic of the genes and saying, not only do you have this and this pathological mutation, or you're a carrier of this and this disease, which is important, which is good to have a WGS, but also the polygenic risk score, really to see the mosaic of where is the patient standing in terms of risk to develop a disease at a specific point of time that is really correlated to mortality. So CVS and dementia and their own. So not only cancer. And pharmacogenomics. Luckily, it's really becoming a mainstream, and most clinics I've been working with, public setting, also have pharmacogenomics being done at least once, and where we are guiding our treatment, if a treatment is needed, with the help of pharmacogenomics. And last but not least, of course, wearables. I personally am a big fan of those. I think it's a great tool for feedback, but also for the doctor to have the chance to have an instant glimpse of continuous monitoring. And besides of the things that we all know from the wearable CGMs, of the bands, of the rings, or the high HRV and all the other vital signs, I think we are all more and more excited also to have the continuous cholesterol monitors being improved and validated, mini polysomnographies, inform even of a ring for the night, that are giving us quite valuable data, for sleep apnea and movement. And last but not least, really a very good monitoring of our liquids as in liquid biopsies, right? So really not only checking in the blood for pan-cancer panels or cancer panels, ctDNAs or RNAs or CTCs, so circulating tumor cells, but more and more in liquids or other samples such as stool, such as urine. Stool is very established already with the Cologuard, but not many people know that, there are urine tests that are testing for prostate and bladder cancer. And hopefully we'll have more and more of those types of fluids that can be tested. And of course, also breath. So volatile particles that are also predictive of cancer, from lung to other endocrine cancers. So I think those things are extremely valuable, because all of those data points, if they can be integrated properly, will give us really a patient's digital twin and help us to understand which of the levels of aging for a specific patient are accelerated. Is it the molecular level, the cell level, tissue, organ system? Is the epigenetic not really fitted for the patient, the influence of the environment? And at the same time, which really of the functions, so the functionalities, which of the functionalities for the patient clinically is decreasing? Is it the vital capacity? Is it really the oligofactory system? Which of the system and the organs and functions altogether are decreasing for a patient specifically? This allows not only to know, but also to optimize the longevity diagnostic and monitoring protocol. And as you can see here, it has to be granular and it has to be individualized. And some things expand, from something that has to be done daily, continuously, and to points that can be done once in a lifetime, such as whole genome sequencing, and then just to recheck for new mutation as our knowledge of genes is growing. But at the same time, this type of protocol is not only about do those tests, take those pills, right? It's a whole package of a longevity protocol, which also it's very important. It's the education of the patient. It's a longevity program ready to strategically tell the patient not only sleep well, eat well, move, but to strategically say, you have to do this exercise so and so many times for so and so many minutes with this and this rate, with this and this times of rest to achieve this and that specific outcome for your caliper or your grip strength or whatsoever this is. So really going very granular and individual for the patient's specific needs. Of course, we have a great help now with the biological aging clocks, and we have a whole variety of those, and they are expanding, and it's just so wonderful to see. By far, what I'm showing here is not everything that we have, and this is just an example of the deep aging clocks. But very valuable to see that the variety that is out there and all the different people who are developing those, there is a very collaborative spirit, because we will need to know which clock is actually measuring what. Besides of the fact to know that, this is my biological age, every doctor and hopefully also the patient will understand what this actually means for me. Why is my epigenetic clock showing me minus 20 years, but my blood clock is showing me plus 5? Where's the problem? How does it differ? How do they measure those values? And so I think it's very important to understand, okay, this algorithm is behind, and epigenetic clocks are measuring your age, but they are oscillating around an axis And the blood clock, for example, is really based on those 45 blood markers. And it is predictive for mortality, but hey, maybe morbidity is different and other factors were not included. And then at some point of time, once hopefully we will have a much bigger data set that will be also shared between each other, we will be able to understand what are the interfunctions and intersections and influences between each other, between those biological aging clocks. On top of that, it will be very important to have specific organ clocks and organ clocks that are working on data sets that are maybe not mainstream. So clocks based on lipidomics, clocks based only on specific function of the heart, but on the structure, not only on the functionality like HRV. Those are the things that are all in a pipeline, not validated, but ongoing. And I think that it's very important for us in the clinic to embrace them in order really to validate. And what is also extremely important and growing, I think, is the focus on a microbiome. So I just wanted to mention that there are already efforts and there are already clocks out there that are based on microbiome, and there are efforts to extend those and to build new, which is, I think, extremely important. Microbiome plays a tremendously important role, but also clocks that are very much focusing on reproductive health in reproductive age and then later menopause, andropause. Especially, I see Aaron is here. He's very focused on menopause and extremely focused on andropause. And I think once we know more, once we really understand longitudinally which hormones are changing, and how can we actually measure the reproductive biological age or have a menopausal clock, we can do a lot more than just HRT, hormone replacement therapy. And then, as I mentioned also before, how can we really see the interactions and the proportions and interchanges of those different clocks between each other? That's very important. And how it usually looks like, for example, for the blood age like this, most of you probably have seen it, maybe some not. We usually, after, fueling in the algorithm, we get an output report. And such a report is giving us the chronological age and then the biological age. So this was actually a patient, young male patient, 41, biological 45, without really many of the factors that were extremely out of the norm, right? So in a normal clinical setting, we'll say, okay, your cholesterol is a bit elevated. 200 is the norm. Anything below is good. Yours is 205, whatever. But as you can see here, it's really about the optimal values. So the norm values are being left out in that sense, and the optimal values for that specific patient at this specific point of time is being listed. And those that are influenceable can be then modified with the help of a doctor to reduce or increase those. And what was very useful is the fact that we can repeat those tests, not every week, not every month, but it's reasonable to repeat them like every 3 months if you want to really intervene and have somebody have a change and do something. We have the longitudinal follow-up, and this was a patient who was actually in August 38 biologically, and then it increased to 44 literally within half a year. And what happened here, the patient started to actually take quite a bit of supplements. I will not mention which ones, but let's say the dose was like triple as high as what would usually be recommended on the supplements, thinking that more is better. But actually, very often in medicine, we say less is more. But this patient didn't really listen. He didn't want to stop the supplements. He continued. And after we measured like another half a year later, he went up, and then he started to listen and to reduce and few things to stop. And then the biological age actually went down. Now it's very good. But it's really a work one-on-one with the patient, and it is scalable, as we can see already with the public departments. It's scalable. It's of course less granular, but it's scalable. And it's all about the right guidance where the continuous monitoring is very helpful, more detailed diagnostic on a larger scale, and really also finding the right medication and or supplements for the patient in specific intervals. Now, therefore, we can follow up the patient.
That we have about 14 minutes left.
Oh, okay, see. Thank you for that. We were chatting in upfront to make sure that I'm not going over time, which I'm apologizing for. Usually I do. So we can really longitudinally follow up the patient and see biologically where the patient is standing. And there are also a few special cases for those who are interested. Sometimes we see a patient, this is just an example of a patient who was chronologically 29, a female, had a problem to get pregnant for no really apparent reasons. Hormones were okay, everything was fine. Structurally, gynecologically, everything was fine. No children. So when we measured the biological age, I just said, let's just do it. Let's see what's going on. And she was biologically 31. You might say the delta is not very big, but actually for a patient at this age, for that specific algorithm, it's a lot. And we know that patients who are getting a delta that is higher very often, and they do not have apparent blood parameters that make them older, so everything is within the norm, very often have autoimmune diseases. And indeed, for that patient was the case. Actually, it was morbus vaginal, so clearly she was, she had great difficulty to get a child. So again, see, things can be detected more than just, saying, this is suboptimal and you can improve. And maybe just for the closure, things that are really that I'm very passionate about. And I think that this will really advance the field is AI-based drug discovery without making promotion for in silico, but they are the leaders. You might have seen the Nature biotech paper that just came out 2 weeks ago about the first drug that was AI discovered and is now in phase 2B. Within less under 18 months, which usually takes years and billions. Anyways, so these AI-based drugs are very interesting because they are using so much data power, they can actually not only focus on the disease, but they also can integrate another function. So they have a dual target. They can target a specific disease, a gene, or, some kinase, some enzyme, but on top of that, do something else. So for example, the drug that was mentioned there is a drug for fibrosis, developed for IPF, idiopathic pulmonary fibrosis, very deadly, a horrible disease where there is no cure. We can only manage it and put it into a chronic state. This drug is actually reversing, but it's also reversing fibrosis, which is one of the main side effects of aging. So that is very interesting. And again, it's extremely scalable because what is happening is huge AI robotic labs, which have 0 people in it, only the robot, they can be miniaturized and placed in the hospitals. So me as a doctor, if I have my patient, I also work as an oncologist. So if I have my patient and I can take a tissue and I can just send it to the robot that will do the high output analysis and fuel it into database that is connected all over the world with my patients, I might find, number one, old targets and find the right medicine for my patient, which is a very easy thing right now to do. But secondly, maybe I can find a new target and somebody else had this target as well. We can compare and we potentially can create a new drug that can we use. So again, how can we bridge the sick care and the new wave of healthy longevity medicine by actually doing? As I mentioned before, we already have healthy longevity department in several hospitals, but at the same time, there are also hospitals that are 100% sick care hospitals, as the one that I'm working, for example, in China, that is transforming on a little bit of a different level because the amount of people is much higher. And what we are doing there is basically building a sort of smart hospital because integration of data in that specific setting is the most important across the globe. With this, I'm going to finish up, thanking you for your attention and very open for any questions and discussion.
Thank you so much. You covered a really wide range there. That's really helpful, and congrats on all of these efforts. I don't know how you possibly could have time for all of this. Thank you. Okay, we have Carl here with his first question, who was waiting for quite some time. And if you want to drop your questions in the chat, you're welcome to do so, or feel free to raise your hand at this point as well.
Very expansive, impressive effort. Obviously the world needs better education of all the physicians on things that are going on in the field that we know and love. So my question is about standard of care, you talked a lot about expansion and diagnostics and stuff, but not, I've heard lots of stuff about the whole effort from you and from Andrea, but I hardly ever hear anything about what the actual advice and standard of care being advocated is, right? What are we teaching? Who's deciding on what standard of care for longevity medicine is? We want it to be more than what normal doctors are trained on. And there are some consensuses from the aging research field, but there's also a lot of controversies and things that we don't know. And yet, individual doctors are making their own recommendations in some of these areas. So how is the society deciding what to put in its courses and what to actually teach people and advocate as standard of care in this area? Is there a plan for, especially for the controversial things where researchers disagree? And is there a plan for some kind of broader global conversation to decide on what it should be in the areas as we get more data? Or is that something that you and the other leaders of the movement see as more appropriate to happen behind closed doors?
I hear you. And in answer to your last question, for sure, no. And I also don't think a society can or is in place to decide anything. At this very moment, I think the society can only facilitate the effort to bring whatever is out there proposed as potential standard of care to higher councils and discuss with them what potentially can be done. But since this will take a long time, therefore, many of you might have heard, and we also among our members and broadly, we said we want to create the working group about the guidelines. But it's not something that will happen immediately. And nobody, in my personal opinion here, is in a position to say this is the standard of care. One can recommend. And this is why I mentioned at the beginning that guidelines have to start with guidelines, how to build guidelines in this field. And this can be only done with task force, with close collaboration with the councils that have been doing this for other disciplines for decades. And then only after that, can recommendations come as recommendations, the lowest level of evidence, and from that guidance. For me, that will take years. Therefore, I think, and definitely nothing should be happening in any field, in my opinion, behind closed doors. But on top of that, I think we also need to do things already on maximum credible level. The public setting, for example, here, of course, we understand that using some of the biological aging clocks might not be in the standard evidence base, but so that's why we do it as a study, right? Every patient who is coming to the center is also a part of a study. And I guess that's very important and will be fueling what later will be the recommendations and guidelines.
Thanks.
Well, we have Larry.
Yeah, I think it was a great presentation. And I think, for patients who can undergo the type of individualized therapy you're recommending, it could be beneficial. The problem is that was touched on, just recently, is coordination of clinical trials, coordination of clinical information. That was the huge problem with COVID, is that, there are all kinds of clinical trials started, but no information came out of them. And I think in longevity, that's, a little bit where they're at now. There's a lot of things going on. There isn't much coordination of effort. I heard Ray Kurzweil give a talk, or was on a podcast. He's taken 80 pills. I don't know, maybe some of them are helping him, maybe some aren't, but there's a lot of this stuff going forward already without very little evidence behind it. Vitamin D, there's some evidence that prevents cancer. There's also evidence that it might, cause heart problems. A lot of these things, to really get the real answer and for which people they'll be beneficial for, it's a bit complicated. But if you don't coordinate studies, we're just going to be at the same place, we are 10 years from now, when people are taking all kinds of things and nobody knows what really works. And there's all kinds of biomarkers out there, and some are contradictory to each other as well. And, I think the important thing are simple studies that, improve people's lives. And I don't know if you need the depth of study that you're doing for that.
So first of all, thanks for mentioning many aspects. And I guess, again, I can speak for me personally, but I know that many people share it. And I'm actually going to quote, I know Dr. Kran here, coordination and collaboration, I think is tremendously important. Most of the clinical trials that are running in oncology, for example, are not exactly coordinated in a way that everybody will need to report to everybody how to do it. There are no massive consortia. But there is a coordination because people talk to each other much more than we can because it's already an established discipline and there is a little bit of a different exchange and there are guidelines that cannot be cross-passed. We are starting something new. I like to compare this to interventional radiology, a discipline that became very successful in a very short period of time. But if you look up for guidelines in interventional radiology, you will not find much, right? But still it's working and it's working very well. So I think coordination is important, but without over-regulation. And at the same time, I think it's also important to exchange data more. So rather than just coordinate, also exchange. And yes, of course, there are plenty of potential biomarkers out there that have been published already since, last decade. I think the consortia that are out there, which I'm a big fan of, is their role is really to at least give us a way to how to validate that even within clinical trials. But one thing I didn't have time to talk about, and which I think is a very important key point in longevity medicine, and hopefully it will be done much more, is the N=1 clinical trial, which is not the same as trying out and anecdotal, but really N1 clinical trial in this setting. I think we will learn a lot from this as well.
Wonderful. We unfortunately only have 1 minute left. And so I always want to finish on the note of, if people are excited about your work and with what you work, many different efforts, how can they learn more? How can they get in touch? Is there anything in particular as a research collaboration or something that you're looking for that people can help with?
Right. I don't have a website or something, but I'm on LinkedIn and I'm hopefully extremely responsive. And I'm always happy about collaborations, extremely much so in terms of clinical trials. And if somebody is working on longevity education, as in clinical councils, medical councils, or somebody is working on clinical trials with repurposed drugs, with analytics, protectors, very happy to collaborate, and AI. So if there are platforms that are aiming at integrating, then, always also very welcome. And in general, always happy to connect.
Wonderful. Thank you so much. I'm really happy that we finally got it to work. Thanks a lot for taking some time out of your really busy schedule.
Thank you so much for having me. It's a great honor and pleasure.
It was really fun. Thanks everyone for joining and for your great questions. And I hope to see you all very soon. Have a wonderful rest of your day. Bye, everyone.